But thanks everyone for joining today. So this is the sixth Impetus webinar, and we are going to talk about how citizen science can engage women in managing their health. Just to give you a quick overview of today's agenda, just have about 5 minutes introduction from me. And then we're going to hear about three really great initiatives that were part of the Impetus Accelerator program. And then we'll have a bit of a panel discussion, probably for about 15 minutes. And then hopefully there'll be time to hear from you if you have any questions to put to the panel. Also, if you're thinking of questions whilst we're speaking, feel free to put them in the chat and we can come back to them towards the end. So just a really quick introduction from me. I'm Alex and I'm based at Nesta's Centre for Collective Intelligence, where we think a lot about different methods to strengthen relationships between communities and institutions to solve societal challenges. Nesta is the UK's social innovation agency. It's a non-profit organisation focused on positive social impact. And I've just shared a link here to our collective intelligence design playbook, which is quite an interesting resource full of kind of tools and tactics and methods to help you design and deliver a collective intelligence project. We can share the slides after if of interest with the links in it. So just a quick overview of Impetus in case you're not familiar with the program. Impetus is a 4-year innovation program to support and give recognition to citizen science by enabling a wider range of citizen science initiatives to access innovative funding. So we support citizen science initiatives through 3 open calls. So we offer €20,000 to kickstart 100 citizen science initiatives. And we also offer a sustaining grant of €10,000 to sustain 25 citizen science initiatives. So Impetus is also involved setting up an accelerator that provides integrated program of support and training and mentoring and resources. We also launched the European Union's Prize for Citizen Science, awarded to citizen science initiatives for outstanding achievements. And then we also work around shaping kind of EU policy in and with citizen science through kind of horizon scanning, action research, policy briefs, these webinars, and also workshops with key policy stakeholders. So that's a brief introduction to Impetus. But before I hand over to the 3 initiatives to hear more about their work, I wanted to introduce the topic of today's webinar, so how citizen science can engage women in managing their own health. So citizen science is an approach that involves the active participation of members of the public in voluntarily contributing to research, including by asking research questions, collecting and/or analysing data, and using the results. And citizen science is promoted as a way of contributing to the opening up of science through the participation of a wide range of different stakeholders, so the public, researchers, decision makers, and industry. And through citizen science, large-scale data collection becomes feasible, but also citizen science creates opportunities for the public to become active participants in shaping research questions and study designs. And one really interesting example is a project called Izala, which focuses on the female microbiome. And it allows women to share their personal health data whilst also kind of learning about their own bodies and the microbes in them. And Izala rapidly grew from an initial goal of kind of getting 200 participants to over 6,000 people participating within 10 days. And this kind of showcases the immense public interest in contributing to vital health research. And Izala is a great example of a collaborative initiative between the public and researchers that not only enriches the scientific process, but it also fosters a kind of community of informed citizens empowered to take charge of their health narratives. And they were awarded the European Union's Grand Prize for Citizen Science in 2023 in recognition of this. But there are also other inspiring initiatives working in this space that we get to hear from today. So I'm going to hand over to each of our three initiatives to very briefly introduce their work and to give a bit of context to their projects before we have a discussion between the panel. As I said, there should hopefully be time to ask questions at the end, but if any questions come to mind whilst the panelists are speaking, please put them in the chat and we can come back to them. So firstly, I am going to hand over to Brittany from the Endo Health Project.
Thank you, Alex. So my colleague and I, we are from the Patient Experience Observatory of the Hospital Clinic of Barcelona. Can you hear me? We're from
Yes.
the Patient Experience Observatory of the Hospital Clinic of Barcelona, and our Endo Health Project is a collaboration between our department and the endometriosis unit. The Endo Health Project, it focuses on developing a new model of care for patients through the use of co-created digital tools. So for some background, endometriosis, it is a chronic inflammatory condition that is characterized by endometrium-like tissue growing outside of the uterus, and it causes several symptoms like pain, infertility, etc. But it is, even though it has a prevalence of affecting 1 in 10 women worldwide, it is still quite an underrepresented condition. For example, the average diagnostic delay is 7 to 10 years. And this is because of a lot of misinformation and stigma within the medical community as well as society at large. So understanding the challenges that the endometriosis patients face, in 2021, the Patient Experience Observatory, we launched a project utilizing to understand the unmet needs of endometriosis patients. So utilizing focus groups, interviews, surveys, etc., we were able to identify 3 main unmet needs. So, for example, patients need tools to reduce the impact of the condition on their daily lives, to provide long-term follow-up and monitoring, as well as the need for more information surrounding the disease and its management. So Endo Health is kind of a spin-off to Endomway. It's like the solution. And the goal is to create a digital platform with co-created tools to combat the unmet needs that were identified from Endomway. Now, we were privileged to be a part of the Impetus Kickstarting as well as the Sustaining programs, and we were able to execute 2 phases of our project. The first phase of the Endo Health project looked at co-creating endometriosis-specific patient-reported outcome measures and patient-reported experience measures, and these are just questionnaires that we'll use to monitor patients. So, for example, the prompt covers symptoms such as maybe pain, in like functionality limitations, fatigue, and so on, while PREM covers domains such as maybe navigability of the system, information provided, communication with healthcare providers. And it's very important that patients are at the forefront of co-creating these because they themselves know what they want to be monitored. And then in Endo Health phase 2, the goal was to identify information and support needs of endometriosis patients and of endometriosis patients. Can you just go back for a second? As well as to co-create therapeutic content based on these needs. So in our project, we had 2 levels of participation: the patient advisory group, and this was just a small group of patients who worked closely with the research team in order to to guide implementation and just be at the forefront of decision making when it came onto the project. And then we had general co-creation participation from a larger pool of patients with less time dedication. You can continue. And then I won't go through our co-creation process, but at the end of the co-creation, at the end of phase one, we had one endometriosis specific patient-reported outcome measure co-created with patients with 8 domains identified as important, as well as one patient-reported experience measure. And we're also able to generate a data set using these co-created questionnaires. And this data set was used to clinically validate the questionnaires for use in the clinical setting. And then at the end of phase two, we were able to co-create 45 videos and like information sheets that covered topics deemed important by patients. So the topics were mindfulness and guided meditation, nutrition, physiotherapy, and general information. Now, just to summarize my summary. So, in terms of impact, we are mostly in the social and scientific realm. So, when it comes to like our social impact, we were able to, empower patients to, become more involved in clinical projects like this, as well as we were able to give them new skills and competencies in health research. And in terms of scientific realm, we're able to address the lack of disease-specific measures because only 48 prompts are used in endometriosis, only seven of which are endometriosis specific, and there are no specific prems, as well as we were able to create a framework for the participations of scientists in, these clinical projects, which we plan on publishing. And then in terms of political impact, we haven't done much work there, but Anne-Sophie, my colleague who is also here, was able to publish a article critiquing the communication strategy of the Spanish law, which grants menstrual leave. And just two last points in terms of impact assessment that was done at the end of phase two. The first point that I want to make is that we were very interested in understanding the clinicians' perception of involving patients in these types of clinical projects. And 60% of clinicians reported that through a project, they had a changed perspective on patient inclusion in clinical projects, which is something we're very happy about. And then my last point is that we asked both patients and clinicians whether they would like to, participate in similar citizen science projects like this in the future, and 100% of them would love to participate in this type of project. I hope I didn't go over time. This is my short summary.
Thank you so much, Brittany. No, that's great. Perfect timing. Um, thanks. So I'm going to hand over to Barbie from the Luna project.
Yeah, hello everyone. My name is Barbi Seme. Thank you for being here today. It will be, I'm sure, very fun and knowledgeable. So we did this project, Luna, which we started with the accelerator program of Impetus. And what we were researching is the experiential landscape of a menstrual cycle. So we know already a lot about menstrual cycles. But mainly from anecdotal data and what we like to call these people wise women, esoteric wise women who give you a lot of suggestions on how to go through the menstrual cycle and each phase. But we are lacking the scientific data. Only recently we have scientific data on phenomenology of a menstrual cycle, but most of them or many of them are quite biased, negatively biased, or biased in the process of data gathering and so on. So we really wanted to co-create a more rigorous approach on how to research the phenomenology. So how is it like to be in certain menstrual cycle phase for individual and then collectively finding the patterns in the menstrual cycle phenomenology. So we were interested in what are the significant experiential differences between menstrual cycle phases. As I said, we did this iterative co-creation process for the research design. So we collaborated with our citizen scientists who were collecting data, evaluating the research design, and then also interpreting the data for themselves, but also for the whole research. And we wanted to have some sort of a tool to support people with menstrual cycles to better track their phenomenology, so their experiences, their thoughts, their emotions, their feelings, bodily feelings, and so on. And then to see if they for themselves can see some sort of patterns. Why? Because then you can assist yourself better in certain situations, because you know approximately when you are going to be in a specific phase. Next slide, Alex, please. So we used experience sampling method, which is quite burdensome method for citizen scientists or participants, because you are using repetitive questionnaires, and you are sampling moments, experiential moments. So this way we reduce the bias, because we don't have any conceptions about the menstrual cycle or how you have to be in specific phase, or some retrospective memory biases and so on. But it's very burdensome. So we tried to come together with having a rigorous method, but also having it reasonable to actually use in day-to-day life when you want to research your own experience. We used this app, Curious About Consciousness, where we gathered all the data and where also citizen scientists had the opportunity to see their data in different visualizations. And with that, they will also be able to report some feedbacks. How useful is this for them? In which way? What would they need, and how would they change this to be more useful for them? We also gather data for psychospecific phenomena like PMS, brain fog, and peak experience. And we also collected data which was suggested by one of the citizen scientists, to compare specific situation like, I don't know, date night in different menstrual cycle phases. So how am I experiencing the date night in menstrual phase? How am I experiencing this during ovulation and, for example, late luteal phase? Next slide, Alex, please. So we have a lot of data, which is still analyzed, interpreted. We were focused more on our scientific impact, but also with these results, we wanted to have more policy-based impact to evaluate some ideas which was already mentioned. For example, menstrual leave. Is this appropriate or not? What are the biases with these kind of regulations and policies? And also to have some sort of impact on local communities, with businesses, with our public education, for example, on how to, we concluded at the end to normalize the experience throughout the menstrual cycle. I also included one very short and quick peek in results, because we have so many of them. Just two examples, which are quite straightforward. So the perceived feeling of being productive is much higher in the middle of the cycle, so around the ovulation, and for example, the preferred activities in different phases. We are very social and like to have social interactions in the middle of the cycle. And we like to rest when we are in the menstrual phase or the late luteal phase. So this is something that we observed and is significant, and we think also very normal, and should be taken as such. So thank you very much. This is my short overview.
Thanks, Barbi. That's great. And for keeping to time. I'm going to hand over to our next project and to Irene to hear about obstetric coevolution.
Sorry, thanks a lot, Alex. This is Irene Lapuente from La Mandarina de Newton, and we are an organization that works on citizen science, science education, and participation. And I'm presenting obstetric evolution, as Alex was saying. If you can put us the next slide, thanks a lot. Obstetric evolution is a project that, as the others, got in the Impetus Accelerator. We also had the Kickstarting and the Sustain grant, which was really good for us. And we also had the help of the City Council of Barcelona, because we are based in Barcelona. We've been working for 3 years now because the project is still alive, which I think it's also good to mention that although we use all the Impetus help, we can go beyond that. And now we are also partnering with another team from Impetus. They had the project Menina, and we got this project to grow in a bigger one. So we are very happy about that. Our research question was how obstetric practices influence mothers' mental health during postpartum, because we had realized that 1 out of 5 women had postpartum depression, and we thought it was quite a high number. So we wanted to do a little bit more of research in that topic. As others were mentioning, there is very few research on or traditional research on these topics. And I think citizen science is a good opportunity to talk about these not so treated topics like it's women's health. One thing we realize is medicalization is in childbirth is higher than recommended. WHO recommends 10% of inductions, for example, and at least in Barcelona, in our area, in Catalonia, they are doing 33% of births are induced. So that's like 3 times what's recommended. It could be okay if that had no impact on women, but if we look at the impact on mental health, this impact is high enough to be considered. 1 out of 4 women have needed mental health treatment, and if you look at them, if there is no intervention, the help that you need is less, so you have less probability of having mental issues after the childbirth. We believe this part is important. Of course, we need to care about the biomedical, biochemistry of childbirth, but also the well-being and the mother mental health should be something to be considered when you decide to propose one obstetric practice or another, and to evaluate the risks. How we find out all this? Well, first we did some co-creation sessions where we identified 5 challenges. We were working with mothers and professionals. In the first stage, we were working separately because we thought each community needed its own time and its own intimacy to talk about it. And with them joining the results from both communities, we identified that there is, as I was saying, higher medicalization than it should be. The communication is not bidirectional, so mothers were complaining about this high down communication. There is a lot of fear before delivery. Mothers are not encouraged to go to the delivery. So then they are more vulnerable because fear is what they make you. There is a lot of mental health issues beyond postpartum depression, like post-traumatic stress disorder. And there is a lot of feeling of loneliness during postpartum. From those challenges, four solutions were proposed, like feedback sessions between mothers and professionals after childbirth, sexual and reproductive health education to be improved, transversal women's circle where you could learn one from the other. No, and maybe in the past we were closer to our sisters or mothers-in-law, and we were more in a community, and where now our motherhood is more isolated. And then dissemination of mothers' needs. From those four solutions, we were able to work on three of them, the postpartum meeting protocol, the educational resources, and the podcast, which is related to communication, to more dissemination of mothers' needs. If you could go to the next slide. Here we have an overview of the three solutions that we were working on during last year. First was a postpartum meeting protocol, and we took a lot of time on this. We were also doing co-creation workshops with mothers and professionals, and then pros and cons were seen, no? Like, for example, usually mothers don't see the professionals who were with them during childbirth, not even when it's a C-section, no, a cesarean section, which is like a chirurgy. And usually when you go into chirurgy, you see the person who's performed. But we also saw complications in this postpartum meeting. So eventually we developed a best practice decalogue, and this booklet that you can see here, that it's like a notebook that you could follow all your pregnancy and delivery and postpartum. This used to be in the past, but it disappeared. So we've worked and updated to see if that's a possibility to also maintain like a stable follow-up of the pregnancy, which is not at the moment a reality in Spain either. We are now on the phase of proof of test. We have the prototypes, and we are working with mothers to see if this improves and reduces postpartum depression. We also had a hackathon where we developed 3 educational resources, one for kindergarten, one for primary, and one for secondary. The idea is that introducing that we are mammals and that we are born this way, and it's interesting to see how education is focused more on sexual transmitted diseases, but not so much in the natural way of being born. So we are doing the emphasis on being mammals, on affection and sexual relationships, and then becoming a mother. And then we had a whole season of podcasts based on motherhood, from getting pregnant to studies in anthropology and psychology and midwife. So it was a whole 12 chapter season on motherhood. If we go beyond this, apart from those 3 materials that you can see here, the booklet to follow up and research, this is very important for us because it allows us that mothers feel that they have something to do a follow-up, but also gives us data to do some research. One of the problems, as Barbi was mentioning in her project, is that there is no much data. It's very hard to get data from these topics, and that's why there is also very little research. And here you have how we have shared the educational resources. They have like a canvas, so any teacher, this is open, can use these materials, and you also have this impact on communication, talking to all these people and professionals. We've disseminated beyond the science community because we've gone to many conferences. Here it says 9, but maybe now they are more because we've lost count a little bit. We also been in press articles, 4 press articles, 5 radio interviews, the podcast, as I was saying, and over 400 women were participating. One thing we realized is women really want to talk about it. And one thing that for me it's interesting is when I explain the project to someone, if it's a woman, they probably will explain if they had babies, how was their childbirth, which is meaningful. Not a couple of weekends ago, we were on the science fair in Barcelona, and we had a lot of public coming and talking about how we were born. Because if we think about it, we talk very little about that. Have you asked your mother how you were born? We know when we have babies, but what about us, no? And the idea is to work on those 2 SDOs. One is related to health and well-being, and the other gender equity, because our impact is being scientific, but mostly social and some political impact too.
Thank you so much, everyone, for very brief overviews of your projects. I'm going to move us into a bit of a panel discussion, so hopefully we can explore some of these points that you've raised. I'm going to stop sharing my screen as well so that we can actually see people's faces, which is good. But I wanted to ask, I think it's something that you've all touched upon and you actually just kind of referred to it, Irene. But so citizen science can generate lots of data, and like you each mentioned different kind of data sets and data that was created in your projects. But it's not only about filling data gaps, and I wondered what other benefits there are to using a citizen science approach to engage specific groups.
Well, I think maybe my colleagues want also to say something, but I think it's very important for these underrepresented topics and also to see in places that they are not looking. Barbi was also saying this bias of the science, they already exist in science. And just today I read it's education, but it's still the same. 4 months after a boy and a girl start school is when girls decide that they are less capable to do maths. So before school, they both more or less have the same courage and the same enthusiasm, but 4 months later, they think, oh no, that's for men. And that's from school. So imagine if all our teachers, they have this bias, all our doctors have bias, because we've been very shocked working with professionals about sentences that they say. Well, I think citizen science allows us to go there, to see our bias, to see things that it's very hard to see otherwise, because the culture, the general culture is so big that goes, like a truck. So for me, it's to see hidden aspects of reality.
Yeah, and just to complement is for us specifically within the healthcare sector, citizen science helps us to address issues that are, really deemed important by patients. For example, in our context, we're able to collect patient-reported data, which it's good for monitoring patients at an individual level, but also at the meso and macro level. It's good for driving service improvements and so on. So it helps us to address. It helps us to create a healthcare system that is very patient-centered as we move towards like more value-based healthcare.
I would also add one thing. So with us, bias was a very common topic in the project. And as I mentioned, all of this esoteric knowledge about menstrual cycles and that you are more creative in certain phases and so on. We had quite some citizen scientists who were well aware of that, but they were not very familiar with the scientific method. So also this way around to bring the scientific method and the rigorous approach to the people with citizen scientists.
Thanks so much. That actually, thanks, Barbi. That brings me on really neatly to the next question. But I guess in these kind of or this area of citizen science around health and women's health, we often see kind of bottom-up citizen science initiatives or ones that are community-led. And I wondered if there are kind of particular ethical considerations to be aware of, but also like how do you navigate kind of varying levels of health literacy, like with different participants?
For us, in terms of health literacy, in all the phases of our project, we tend to have like a fun introductory session where we kind of like balance the playing field. So we introduce the project, we introduce them to the medical terms that will be used throughout the project, any information that they need to know before we get into co-creation to ensure that everybody has the same level of literacy about the project itself. So we found that to be very beneficial, and it's a requirement for participants to, do that introductory session before, we go into the co-creation itself.
In our case, when we were working with mothers and professionals, we were asking for different things, and I think that's something interesting of citizen science is sometimes there is no the critique of maybe citizens might not know everything. Well, it depends what you are expecting from them or what you are asking about them. No, also Brittany was saying the patients are the ones who know the most how they feel, if they have pain, if what are the consequences of having this. Well, it's a little bit the same with mothers. When we were working on the empathy workshops, we were asking about their experience. And for example, inductions are increasing in our country, and it seems that they are okay and there is no consequences for mothers, but there is an article that says that 98% of women who had an induction would not do it again, or if they had to do it, they would postpone it at maximum. Well, we were able to see that in firsthand because they were expressing what meant inductions for them. And I think doctors, they can know a lot about, and researchers, they can know a lot about what oxytocin does as a biological thing, but they don't know how you experience that. And they don't know, like, okay, that means that you are tied to a room. No, you are on the bed and you are tied because you have to be monitored. How does it feel to be tied when you are doing childbirth? So all these topics, it's new for them as well too. So of course, you have to share some like common information and like general knowledge about childbirth, but at the same time, if you ask for different things, I think you get responses from what they know, and then there is a lot of exchange information between professionals and patients because they share table. Like for example, on the empathy workshops, we work on separate teams, but then on the ideation and prototyping, we work together. And there is just a question for me on the chat that says, how is it citizen science your project? Well, because we did we did empathy, ideation, and prototyping with mothers and professionals. We were working with them to develop everything we've done. It's done by them. We just follow the path. And I don't know, maybe Barbi wants to go on.
Yeah, maybe I can add something, or perhaps we can give Maya the chance to ask the question.
So thank you so much, because actually my question is related to what was just said. So thank you so much. I was asking, I live in Milan in Italy, and actually here the trend was that inductions were a way to plan the day you give birth. And it was due to COVID in the first hand, but then they got used to that. So and it became a sort of something that is common use. And I don't know. I was lucky I gave birth before, just before COVID. So it was not my experience, but I wonder if it was something that happened not only in Italy, but also in other parts of Europe. I see that you're.
Thanks a lot for your question, Maya. Yeah, I think that's we haven't gone in deep on that topic, but we've seen relationships with COVID. With COVID, there were some measures that they were taking just because there was a special condition. And as you say, some of them, they've become a tendency and we haven't taken back because they are more practical in the terms of efficiency, not like hospital efficiency, economic efficiency. And I think that's a pity. In fact, recently there was also an article about measuring the heartbeat of your child if you have high risk delivery and there is complicated, might be of use, but if not, there is it doesn't add any extra information, or it's but for the mother, this is really, really annoying because that means that, as I say, you are tied to something and you have pressure on your belly. But because you have extra data, you might not do nothing about it, but you just in case you put it, no? And this is something, it started as experiment. Let's monitorize women while they are having babies. And now in some hospitals, that's like a routine. They do it just because they've always done it. So that's something that happens. And I think that's why we also have to be careful and keep saying and looking and trying to raise these things.
Thank you.
Well, to the previous question, I was just wanting to add something about the literacy. So we were looking in phenomenology, the experience, how is it like to experience something in certain context? And many of these people, citizen scientists who participated already were tracking their menstrual cycles. So they were tracking the flow, how their body felt, what emotions perhaps they were feeling. But we also provided some more in-depth neurological research, for example, mind wandering. So we were looking into how frequent do you mind wander and what are you mind wandering about? And is this specific to certain phases or not? And how is this experienced? And is it difficult to stop mind wandering in certain phases and go back to work? Which is very useful to know because then you are so much more prepared. And it was essential to have these citizen scientists who are actually interested in their inner experience, so they were able to research their inner world with us as co-researchers.
So much for adding that. I wanted to ask another question. I think we still got some time about how, because yeah, in some of the projects you'd mentioned co-creation, and I wondered how you might have managed kind of differences in expectations or conflicting ideas between participants and the research team during the project.
Well, we had some conflicting interests between citizen scientists and researchers, specifically about the research design. And through this, we saw that we can never have perfect research design because some people, especially for the phenomenology, which is so personal, subjective, you just can't prepare the questions and prompts for them to answer in a way that everyone would be happy with them. So some people like to give answers to certain types of questions, like, I don't know, scales from 0 to 100%. And other people like to give descriptive answers. So we were really looking into how to make modular research design, so each type of a person can use a specific one, so it's tailored to them specifically. And yeah, we had many discussions around this with a lot of citizen scientists, and we gathered a lot of suggestions on how to improve the design.
Yeah, and for us, it's a work in progress. So, majority of like the conflicts that we saw within our project, or like the, disagreeing like ideas, came from among participants themselves. And usually, democracy works for us. Um, but also, in terms of when it comes to us, into disagreements with the participants itself, we at the start of the project we tend to set expectations. Like, so we are quite aligned. We're quite transparent in terms of our resources, in terms of what we're able to do, and that setting the expectation from the start kind of like, balances out any conflict that like may arise in the future. But we're still learning, and we're still learning about engagement. So yeah.
For us, we know that there is a concept that at the moment creates a lot of conflict, that is obstetric violence. And this has been complicated because our conflict was more on professionals than on mothers. Mothers really wanted to participate, and even though told them that they were going to be anonymized and everything was going to be, they were no, I want to speak up, I want to tell. And there is a lot of need to tell what happened and to tell the stories. In fact, one of the evolutions with this bigger project that I was mentioning that we are doing with Melina is getting all these testimonies, no, all these experiences. Some of them are going to be recorded because there is a lot of need of speak up. But professionals, some of them, they are cautious about. We tried not to use the word or the concept obstetric violence, but it was on the atmosphere because some of these practices, they are done, as we were saying, to go faster or to have the schedule on the hospital, or just because you have too much work and you can't care about rethinking how you're going to do it, or ask the mother, no, you haven't slept, so why are you going to ask the mother if that feels right or not? And they feel like that's criticism for them. But we were talking, this is systemic. I start saying that no, at the schools, girls, they lose their confidence when up 4 months after they started. So this is not a personal thing. We are not criticizing someone in particular. This is a systemic lack of considering women as humans. It's as basic as that. We just consider that they cry too much. They no they their feedback is not valid. We don't have to take it in consideration. The baby is more valuable than that mother's experience, etc., etc. So for us, it was more complicated with professionals, although we had a lot of good professionals that they walk aside us and they saw that we were trying to improve service. As I was saying on the chat, our main focus was not criticizing anybody, but improving service. It was service design research mostly. So
Thank you. Thank you so much. Um, does anyone have a question? I can see there's one from Catherine in the chat. I wondered if you wanted to come off mute or whether noisy. Okay. Yeah, so the question was around kind of in university research projects, there are ethics committees that exist to highlight potential issues and suggest solutions on everything from secure data storage to support participants in discussing difficult life experiences. And also journals require ethics committees approval to publish the findings. So the question is, how do you approach research ethics in citizen science, and are you linked with institutions that support this?
So we did the project at the university. So we gathered the ethics committee approval. We got the approval. But also we were very careful with the data because these are personal descriptions, personal states. So all the data was anonymized already before it got to the researchers. So not even researchers were able to know which citizen science provided which data. We were very careful with this, and we still are. We have two data sets in open access, and they're completely anonymized.
So for us, we operate within the hospital setting, and we do have an ethics committee that we had to, get approval for both phases of our project. For us, it's mostly sharing like experiences, but the data is like coming out of co-creation is aggregated data, so it's not attached to one individual participant, as well as for the cross-sectional study, it's also anonymized. So that's how we dealt with it.
In our case, we also use a lot of co-creation. So as Brittany was saying, is aggregated data and is not attached to someone particularly. They work in teams and they work with templates, and it's all anonymized. In fact, most of the feedback that we don't even know who a specific person said it, because as we were saying in co-creation, sometimes you don't know exactly who did it. We also did a 80 question survey, and in this case, again, is all anonymized, and we use codes for doing so. And we were very careful and very tactful with the needs of the women.
Thanks. Go ahead, Anne-Sophie.
Hi, everybody. Yes, I'm Brittany's colleague, and I wanted to add something on this point and ask about your experience. So, as she said, within the context of the hospital and clinical research or basic research, it's very standard that you have to go through an ethical committee approval before you can start your project. But our feeling is that our ethical committee is not prepared or trained somehow to assess citizen science project. And sometimes the feedback that we receive, for example, they have asked us to keep in the informed consent a specific paragraph that did not apply for the type of project we were running, but out of legal consideration, they say, okay, just in case we should, but then from the patient perspective, it might not make sense. So I was wondering, in your countries, or even in Spain, but in different settings, would you say that ethical committee are prepared to assess citizen science project, or would it be a need like to to provide training as well to the people that are the one supporting and revising and helping somehow researchers to implement the highest quality research project possible? Thanks.
For us, for example, it was quite challenging because we were changing the research design throughout the project, because we were updating it with the feedbacks from citizen scientists. And this was quite hard to understand in the when we tried to get the approval. But then we found a solution how to phrase this in the application, so that we know that research design is changing, and all the revisions will be archived and will not go across all of these points that we already agreed on. So no participant or citizen science in our case is being harmed in any way.
Does anyone else have reflections on kind of ethics committee recognition of citizen science or more participatory projects? I don't know, in different contexts. I know that, yeah, as part of Impetus, it's something that we like really focus on in terms of training and support. And we really encourage the initiatives going through the accelerator to seek ethical approval in their institutions. But I guess it depends a lot on different disciplines and different contexts. Yeah, that's a very general answer to your point, but I think it's a really interesting one in terms of, yeah, recognizing these types of kind of innovative approaches and new methods. If there aren't any other questions, I was going to ask one really briefly before we wrap up, which was just around, and I guess it maybe links a little bit to the question in the chat around whether any of the initiatives had a public involvement professional in your teams. But I was interested in the strategies that you'd use to kind of recruit, but also to sustain engagement in the projects, like in the different phases of your projects.
So for us, we're operating within a hospital context. So we're recruiting within the hospital. We're recruiting patients. So I guess, well, Anne-Sophie, she's a public involvement manager. So we have her recruiting and like, guiding the implementation of the projects. But in terms of recruitment and engagement and how we sustain that, so within the patient observatory, we already had like a database of participants that we were able to reach out to, as well as for our patient advisory group. The goal was to recruit people of different demographics, so we have different representations. So we kind of did like a whole interview process, survey, looking at like who we had from phase 1 within the group and what was missing in terms of demographics. And in terms of engagement, we're still learning. But in terms of how we sustained it, is that we had like a constant feedback loop. For example, I remember in phase 1 of the project, we would have one session for each co-creation activity, but then patients, they would say, well, we have work, we'd love to be involved, but we can't come out. So in the second phase, we adapted it to like 3 co-creation sessions per activity. So it's just that in terms of engagement, it's that constant feedback loop, setting in expectations from the start and so on. But it's a learning process, and like I'm excited to hear what you guys have done.
And just to quickly add, sorry, because something that is important, and it's a bit short in terms of time, but also for the second phase and for the patient advisory committee, because we realized, well, they have dedicated so much time to the project and they have done so much work that it should be also remunerated in terms, in financial incentive, because, otherwise it's all voluntary. So we also done that. And some of them, by the way, saying, no, I don't want it. It's just altruism. And we're like, no, this is your time. You're working besides, having your disease, your family, so it needs to be recognized. And this is how we have approaches with the capacity of the funding that we had to also give them to them as well.
Thanks, Brittany and Sophie. In our case, it's very, very different because we are not from a hospital, so we didn't have the patients. But in our case, they were asking, do you have a public engagement person in the team? Well, we are specialized on that. So yeah, we did. And we did open calls, and then we addressed to like associations, and already that's something that helps a lot when they are already created communities, and that was for professionals, like midwives associations, obstetricians associations, hospitals, but also for mothers. Like even we went to kindergartens because we are sure they are mothers, so it's like going to look for them. And the good thing that we experience is we said we had over 400 mothers participating, but we had a smaller group that they were more constant, and they stay with us for the 3 years. And that's been very, very nice because it's we have created like a smaller community of psychologists, mothers, and some obstetrician professionals, midwives and obstetric doctors that they care so much about the project that we also have like a smaller group, even WhatsApp team that we talk and we share the conferences and the publications and things, and we update each other because we are all concerned and interested in the topic. And well, it's been very nice to see how you grow sort of a small community within the context. So that's how we got it.
Well, for us, the recruitment and engagement was like another full-time job for this project, because we were so general in our research, and we wanted to include people with different demographics. We had this wide invitation, and what we found useful was social media the most. But then also, I should mention the numbers. We recruited around 130 citizen scientists to participate in the whole, all the phases of the project. But then around 70 were actually actively engaged in all of the activities. So it's quite a dropout. But of course, this was very demanding for them. They were sampling 35 days. They were interpreting the data. Some of them were also communicating the project and the results and the method. So it was a lot. And we tried to compensate them with personal analysis of the data they received at the end of the project. So this was like 20, 30 pages long PDF for each citizen scientist. So they could go really into the nitty-gritty of their cycle around there in November and December. And for many of them, this was, well, the interesting thing was that around half of them expressed gratitude that we are doing this project so they can learn more about their own cycle, but also because we as a society need to learn or accept things about menstrual cycles. Yeah, so that was very nice to receive.
Thank you so much for sharing that. I'm conscious of the time, and we're unfortunately at time. But thank you everyone for joining us. But thank you especially to our speakers for sharing such amazing insights into your work. I wanted to just very quickly share one slide just about the rest of the webinars. Well, actually, I was going to mention that we've got an impetus policy brief coming out very soon on citizen science and social inclusion. We're actually going to take a break from the webinars over the summer because there's lots of other activities going on and opportunities to gather in person. Oh, sorry. So yeah, but we'll be back with an online program in the autumn of this year. If anyone's in London, we have some 2 data walks that we're running at the beginning of July. So that's an opportunity to meet in person. And then also at the Ars Electronica Festival in September in Linz in Austria, which will be a big impetus final event and showcase. So hopefully there's lots of contact details shared in the chat for people if you want to follow up. But yeah, thanks again for joining us, and yeah, have a good rest of the week.